Okay, 15 past 12, I think it's time to start. Hello everyone, a very good afternoon and welcome to this symposium sponsored by G Healthcare. My name is Marco Luchetti, I'm the Medical Director for Europe, Middle East and Africa at G Healthcare. And today we are going to speak about different ways to elevate perioperative care by improving patient safety and workflow efficiency. We will have three prominent speakers today, and each of them will be presenting for 15 minutes. Then we'll have around 10 minutes, hopefully, in the end for question and answers. We'll use a Slido app, so on-site participants and also remote participants can input your question on Slido app, but you can also reach out to those two microphones. You have one there and one on the other side. So if you want to speak up and ask questions in the end, you are welcome to do so. And now, without further ado, let me introduce the moderator of this session, Dr. Justin Kirk-Bayley. He is going to chair the sympo and also will be one of the speakers and also facilitate in the end the Q&A session. Justin Kirk-Bayley is an intensivist and anesthetist from Guildford, England. He trained in the United Kingdom and Australia, has been using clinical ultrasound for over 20 years and forms part of the UK group Shaping Training and Education in Point-of-Care Ultrasound in Intensive Care. He was the first in the UK to run a dedicated apprentice-style fellowship on intensive care ultrasound and is invited internationally to talk on point-of-care diagnostics. Justin, please, the floor is yours, and up to you to introduce the other speakers.
Thank you very much. Thank you. So it gives me great pleasure to introduce my first speaker today, and we have Frederic Michard. He's a critical care MD and PhD. He trained in Paris, France, and also in Boston, the United States. He's known for his research work and publication with over 12,000 citations on Google Scholar on pulse pressure variation, PPV, fluid responsiveness, hemodynamic monitoring, and more recently on digital innovations, AI-enabled tools, and also wearable sensors. Since 2016, he's been running a consulting and research firm, Myco, based in Switzerland. And Frederic is going to talk to us about protecting patients, the case for wireless wearables on the wards. So Frederic, thank you very much. The floor is yours.
Thank you very much. Hello, everyone. Thanks a lot for the invitation. Yes, first of all, I'd like to disclose the fact that, or repeat the fact that I'm today leading a consulting and a research company, Myco, based in Switzerland, where we focus on digital innovations with medical applications. So why should we monitor ward patients differently? As you know better than me, many patients go to the hospital for surgery and have to stay for complications. This is the large international surgical outcome study published a few years ago in the British Journal of Anesthesia, showing that on average, 17% of surgical patients develop at least one postoperative complication. It's 27% after a major surgery. So clearly, many high-risk surgical patients develop postoperative complications, and these complications may be detected with a delay, mainly because nurses are spot-checking vital signs from time to time, usually every 4 to 6 or 8 hours. And now we are able to monitor vital signs continuously. We can quantify actually how much we miss with this intermittent spot check. So this is a very interesting study from the Cleveland Clinic where nurses were measuring vital signs every 4 hours. And they realized that they were missing 82% of hypoxemic events and 79% of hypotensive events. So obviously we are missing a lot, many events, many adverse events with intermittent monitoring. We all know opioids may induce respiratory depression, and there is today a consensus to say that no patient should be harmed by opioid-induced respiratory depression. I will here simply quote Dan Sessler in this editorial published in Anesthesiology a few years ago. It is likely that many catastrophic respiratory events could be prevented if we were monitoring continuously respiratory variables. The nurse-to-patient ratio is often suboptimal, on the wards. We all know that. And I like this systematic review published in Surgery a few years ago, showing a relationship, an inverse relationship between failure to rescue, that is to say deaths related to postoperative complication, and the nurse staffing level. So here we have two options. We can either dramatically increase the number of nurses working on surgical wards, but we all know it's not going to happen. Or we can try to improve the way we monitor patients on the wards and the way we detect clinical deterioration. In-hospital cardiac arrest often occur on the wards. This is a very interesting audit study published by the team of Jerry Nolan, done in the UK. You see a large number of acute hospitals, a very large number of in-hospital cardiac arrest. And as a matter of fact, the majority of these arrests are occurring on regular wards, not in very acute settings like the ICU or the emergency department. There is also obviously a trend towards the admission of older patients with multiple comorbidities who are at higher risk of clinical deterioration. And the problem is that overwhelmed ICUs cannot always cope with the surge of acutely ill patients. It became obvious during the COVID-19 pandemic, and that's why with Bernd Sogol from Germany and Benoît Vallée from France, we propose not only to increase the number of ICU beds, but also to upgrade the way we monitor patients on regular wards. And it's possible because there are now, today, remote and wireless monitoring solutions available. So which variables should we monitor more closely? There are different ways to answer that question. We can first look at triggers for rapid response team activation, and you see these 4 vital signs are actually very useful. Rapid response team are very often activated by a rise in heart rate, a low SpO2, a rise in respiratory rate, or a decrease in blood pressure. Another way to answer the question is to look at studies using machine learning algorithms to predict severe adverse events, for instance, cardiac arrest, the need for ICU transfer, or death. And this is an example, a study published in the US a few years ago. And then they ranked vital signs according to their predictive value in their machine learning model. And you think respiratory rate was actually ranked number 1. What are now the existing remote and wireless solutions? So clearly to measure or monitor pulse rate, it's not a big deal. You need a pulse oximeter. To monitor heart rate, or ECG, one lead, you need 2 skin electrodes, which are today very often combined in the same sensor. To monitor SpO2, you need a pulse oximeter. There are miniaturized pulse oximeters now available. I mean, they have been increasingly used during the COVID-19 pandemic, mainly for self-monitoring, but we could use them as well for continuous monitoring on hospital wards, pending, of course, they are used in combination with a gateway that will continuously transmit the information to the central station or directly to the pager or the smartphone of the nurse. Respiratory rate, as I said, is probably the most important variable to monitor because the most sensitive, abnormal in many different situations, not only in case of respiratory complications, but it's still today the neglected vital sign. So that's why I think so many methods and techniques have been proposed over the last 5 years to better monitor and to monitor continuously respiratory wards in ambulatory patients, respiratory rates, in ambulatory patients. So I'm not going to describe all these methods. I'm just going to share with you a few examples. I mean, this is an adhesive patch using ECG variability and accelerometer data to compute respiratory rate. And this is a so-called validation study using a reference method on the x-axis. And you see that only 77% of the measurements were in the safe zones A and B of the Clark-Error grid. This one is a different system with 3 electrodes using impedance pneumography. It's a wireless system. And you see same kind of validation study, this time with over 99% of measurements in the safe zones A and B of the Clark-Error grid. But just to highlight that all systems have not been created equal. The reason why this system is working pretty well is probably because when you have 3 electrodes, you have at least 2 signals. One that could be an abdominal signal and the other one a thoracic signal. So if for any reason, like in this example, you don't get the information from the abdominal signal, very likely you will get it from the other one. Blood pressure. Blood pressure is still the challenging variable. There are a few methods which have been proposed, but I think none of them is really ready for prime time. Some are based on the pulse wave transit time or the pulse arrival time method. So when you monitor continuously ECG and pulse oximetry, you can combine these two signals to predict or estimate blood pressure, or if not blood pressure, at least to detect changes in blood pressure. What's probably more promising, or at least more exciting, is using machine learning simply with a pulse oximetry waveform. The idea is to feed a machine learning algorithm with a huge number of pulse oximetry waveform and corresponding blood pressure values. And then the machine learning system will learn how to recognize specific patterns characteristic of changes in blood pressure, either a decrease or rise in blood pressure. So this is an example. This is a study coming from Lausanne University Hospital, the group of Patrick Schottker. They used exclusively the pulse oximetry waveform to track changes in blood pressure during anesthesia induction. And you see on the left-hand side, the systolic arterial pressure changes. On the right-hand side, the mean arterial pressure changes, and obviously was working pretty well. But of course, one of the key questions is, are these tools really useful to improve patient safety? At the end of the day, this is what really matters. The idea is, of course, to detect at an earlier stage clinical deterioration, and then to have time to prevent severe adverse events, and so ultimately decrease rapid response team calls, ICU admissions, and cardiac arrest. That's the concept. And interestingly, actually, there are already several outcome studies confirming what we expect is actually happening. This is a table we published with Kirk-Bayley already two years ago in anesthesiology. At that time, we had 5 studies, which are very large studies, reporting a decrease in rapid response team calls, a decrease in ICU admission, a decrease in cardiac arrest. I have updated the table for this presentation. Today, we have actually 9 studies for a total of over 150,000 patients showing clinical benefits when monitoring vital signs continuously. Of course, there are challenges to implementation. And to better understand, expectations from anesthesiologists, but also challenges, we did a survey last year. We surveyed over 1,000 anesthesiologists from Western Europe and from the US. And to the question, what are the main implementation challenges, they all said, number 1 is economic. And I think it's important to realize that if we can effectively decrease ICU admission, we should be able actually to save money. This is a small but interesting study coming from the US, where they implemented continuous monitoring on a small hospital ward, and they actually reported savings ranging between 200 and 700 per patient with an hospital break-even after 6 to 9 months. That's another one, a very recent one. It's a modelization showing that continuous vital sign monitoring in a medical surgical unit may enable savings ranging between $3 and $7 million a year per average US hospital. The second challenge is connectivity, IT, and we are all familiar with disruption when we are using Bluetooth connectivity, and that's an example where you see 22 patients on the y-axis. On the x-axis, you have 7 days, so 22 patients were monitored with a wireless sensor using a Bluetooth connectivity. In green, it's when actually they were receiving the signal. In red, it's when they were not receiving the signal, and you see for some patients was really a big problem. So just to put things into perspective, if you monitor patients from home, by definition, they are not very sick, so I don't think you need really continuous monitoring. If you get some kind of repeated spot check, it's not a big deal, so Bluetooth is possibly acceptable. In the hospital, no. If you stay in the hospital, you need to be sure that your vitals will be monitored continuously 100% of the time. So that's why we need medical-grade connectivity protocols. Nurse pushback is classical as well because nurses have in mind existing monitoring systems. I think it's very important to understand that these systems are now equipped with smart algorithms, helping to filter artifacts and prevent false alarms. But it's also important to acknowledge that at the very beginning of the implementation phase, that may be associated with a small increase in nurse workload. But clearly the idea after a few months is actually to decrease nurse workload because, of these repetitive tasks, measuring vital signs manually. It will be done automatically and continuously. Last but not least, I like this one, where alarms should be heard. I was glad to see only 12% of anesthesiologists consider it should be heard in the patient room, because I think it's important to realize alarms have not been designed to disturb patients, but to inform clinicians. So I think we need systems able to keep quiet, silent in the room, and simply inform clinicians on the central station or on the smartphone. So in conclusion, I hope you agree with me, it's time to rethink the way we monitor patients on hospital wards. Clinical deterioration may be overlooked for hours. It makes sense to believe so, but we have evidence quantifying that. Solutions now exist for the automatic, continuous, and mobile monitoring of vital signs. They may help to improve patient safety and satisfaction and to decrease ICU admission and related costs. So if tomorrow you want to implement such a system in your own hospital, here is my wish list and recommendation. You need mobile solutions because we all know that after surgery, early mobilization is a key element of enhanced recovery programs. So out, capnography, bed sensors, video monitoring. You need something comfortable to wear, otherwise it will never be accepted by patients. You need something easy to use, otherwise it will never be accepted by nurses. You need medical grade connectivity, otherwise you will have disruptions all the time. You need a system able to keep quiet, silent in the patient room to respect patient and improve recovery as well. And of course, data have to be transmitted to the electronic medical record system so that scores like the early warning score or even more sophisticated score can be calculated automatically. With that, I thank you very much for your attention.
Thank you very much, Frederic, for your excellent presentation. Now it's time to move on to the next speaker, Justin Kirk-Bayley. We already learned about his background and expertise, so today we'll speak about the power of the ultrasound probe you already have. Please, Justin.
Thank you, Marco. So I've been in love with ultrasound for about 20 years now, as I've said, and my disclosures are that I work in the NHS in the UK as a full-time intensive anaesthetist, and probably not a day goes by where I don't integrate ultrasound into my clinical practice, and I've been kindly sponsored by GE to talk to you today. I'm hoping that in the next 14.5 minutes, I can give you some inspiration. Open your eyes to ultrasound if you don't use it, or if you do use it, at least give you some new horizons and show you how it is developing and how it's going to improve your practice. I'm assuming with the title of the Congress that it's Euroanaesthesia. Most people do anesthesia, but also I do ITU, so there's some extra bits for ITU as well. And of course, the two worlds definitely collide on a day-to-day basis. So where have we come to? What's the past of ultrasound? Well, most of us sort of cut our teeth on a machine like this that's appeared in the operating theatres or in the intensive care unit. And we've got a high-frequency linear probe there that's allowed us, mostly as our introduction to the use of clinical ultrasound, to put in central venous access devices. And we spent a bit of time as residents, as trainee anaesthetists, trying to work out where the bounce of the internal jugular vein is, not sticking our line into the carotid, and making sure that we can then not puncture the lungs and improve our safety profile. That's where most people get their introductions to medical ultrasound when they're anesthesiologists or intensivists. Some people are a little bit more lightened, and they have an introduction into regional anesthesia. And of course, ultrasound has really taken off in the world of regional anesthesia. And there are lots of talks in the next couple of days all about that. First thing you tend to learn to do is to scan up from the supraclavicular brachial plexus up towards the interscalene, work out where one of the more relatively easy blocks are, and be able to put your local anesthesia and deliver anesthesia for shoulder and arm surgery. That's kind of where most of us cut our teeth. That's where we started. That's where we got the stabilizers, and that's where we've moved on from. But there's an awful lot more going on with ultrasound in anesthesia and intensive care at the moment. There's a huge amount of work. Not a day goes by without publishing of papers in various aspects, and you'll see some of the stuff obviously around and about. I'm going to open your eyes to some things that may be useful to you, because that's what I want to talk about. Imagine a situation whereby you are anticipating a difficult laryngoscopy. Not all patients have surface anatomy that looks like this when you're trying to think where the cricothyroid membrane might be, just when you go down to plan D and think, actually, I might have to have some emergency front of neck access. It can be quite difficult to palpate patients, especially if you have patients like this, which turn up on my anesthesia list all too frequently. If I want to think about what's going to happen if I can't secure my airway and I want to pre-mark up where the cricothyroid membrane might be, I can't do it by palpation. And I definitely can't do it by palpation. So this group got a load of subjects, and what they did is they gave them 10 seconds. 10 seconds to work out where that cricothyroid membrane was in a group of patients with increasing body mass indices. And as you can see, actually their distance to where the membrane really was even harder the larger the patients. And that really reflects real life, doesn't it? Because it is incredibly difficult. So imagine if you could use ultrasound. Imagine if you could see beneath the skin and you could work out exactly where you're going. So I've got my ultrasound probe here, and I'm scanning from head down to toe, from cephalad to caulad. The superficial structure that's pointy and comes up to the skin, especially mostly in men, is the thyroid cartilage. And as I come down then towards the toes, down towards the bottom of the patient, I then start to get this very, very clear white, highly echogenic membrane with reverberations for the air tissue border. That is my cricothyroid membrane. It's really easy to see. The ultrasound is very sensitive and very specific. And then I come down and then I'll get my cricoid cartilage. So that reverberation changes. So once I've worked out where it is that my membrane is, what I do is I come back to the reverberation and I get my pen and I put a marker on. Actually, what I use in practice is I get a 2 milliliter syringe, I suck up a little bit of tissue from the skin, and I leave a mark on the skin there by sucking it up with a plunger that lasts about half an hour. Because things happen, patients get sweaty, I get sweaty if there's a difficult airway, and the mark moves, whereas if I leave that marker, I can see it. You can also have it in sagittal plane, of course. This is something that's referred to as the string of pearls sign. I can have a look, and if I put an overlay here for anatomy, what we can see is we've got reverberation from all the tracheal rings on the right-hand side of the screen, and then we've got the cricoid and the thyroid cartilage is in between. You can see it's nice and bright and white with lots of nice reverberations as well down there for the membrane. And it makes it pretty easy to see where it would be if I had to access it in emergency. It's actually quite a good-sized target. This is a trial that we did in Guildford here, looking at ultrasound to see what we can do to improve people's ability to be able to detect it. And we've marked up where it genuinely is on ultrasound previously, put it in ultraviolet so that they can't see it, and then ask them to use ultrasound versus palpation and have a look. And there's their target. It's not too small. But here's a paper that got to publication before us from a group, and they got 120 people, and they said, what's the difference in accuracy between palpation and ultrasound? And it's an 80% compared to an 8% variation. You can see a very tight grouping in the blue dots there for the people using ultrasonographic detection. Really useful. Consider doing that in your day-to-day practice of anesthesia. Whilst we're looking at the front of the neck, if we move to the side to where we were looking at before, looking at the internal jugular vein for cannulation, you'll see there's a little something on the left-hand side of the patient, and that's the esophagus. In the UK, we're often taught in our training that the esophagus sits behind the trachea, so if you press down on the cricoid cartilage, it will occlude it and stop regurgitation. Not so. The esophagus sits very much to the left-hand side, as I've highlighted up here. And if you accidentally intubate it, instead of endotracheal intubation, you get something called the double trachea sign, and it's pretty obvious. Here goes. So once you see that on ultrasound, if you have somebody who's got a probe sitting there with their probe ready to go on the trachea, if you accidentally intubate the esophagus, it will be very obvious to the onlooker. You'll be able to detect that even before you do any gas insufflation. You won't inflate the stomach with any volatile gases or air or oxygen and increase the risk of aspiration, especially when you're doing a rapid sequence induction. Of course, this will happen before you actually do any insufflation, so you won't get any capnography in the esophagus anyway, but then you'll have to have a look and see if this occurs. If you are in the trachea and you start insufflating, you will get capnography. So what I'm saying is that this is a positive prediction. So in the UK, we have a new phrase, which is if there is no capnographic trace, then the tube is in the wrong place. But if you see this, the double trachea sign, then your tube is definitely in the wrong place. And you then don't have to waste some valuable time by trying to work it out. This is probably the best study I found on this basis, which is a group of Saudi doctors, and they've got 120 residents, newly qualified in their anesthesia, and they've given them time to be able to have a look at what's going on with ultrasound to see whether or not the tube is endotracheal or esophageal. And they found that they were able to decide when there was an esophageal intubation a full 15 seconds faster, and it was pretty clear. If you then go all the way up to waiting for 6 capnographic waveforms, it's up to 30 seconds faster. That doesn't sound like an awful long time, but if you have a difficult airway situation and you've got a patient who's rapidly desaturating in front of you, 30 seconds can feel like 30 minutes, as I'm sure you're all too aware. What about interoperatively? What can we do there? What about a situation where you've got a patient who's on the table, they've come to you for emergency surgery, they've got a nasty chest infection, and suddenly your ventilation isn't working quite as well as it was. They're desaturating, you've just intubated them. Yeah, it was a bit difficult, but you're not too sure what's going on. You've had a listen with your stethoscope, kind of sounds okay, I've got equal breath sounds, but it's not quite right. Can you use ultrasound?
So the left is normal, I can see the pleura sliding, but the right just doesn't look right.
So you can put a high-frequency linear probe at the apices of the lung, and you can actually have a look and see what's going on with ultrasound. Far more sensitive and specific for ventilation than it is with auscultation. You can see the lung. Let me show you what it looks like. So this is the kind of picture that you're going to get at about 3.5 centimeters on a relatively thin person with the ultrasound probe. Let's mark up some anatomy for you. You've got skin and superficial fat tissues with a variable degree. Then you've got the chest wall muscles below those. You've got ribs. When we're looking in that rib space between them, right up at the apices, of course, more superior to that will be the clavicle. We've got the intercostal muscles there, internal and external. We've got an acoustic rib shadow, which is the dark bit that sits below. And then we've got this pleura, which when I show it back to you will be a white line that moves backwards and forwards, like little marching ants, backwards and forwards with the ventilation movement of the lung. And of course, below that, we have the lung. Let me animate that for you so you can see that clearly. So this is a normal lung being ventilated, moving backwards and forwards. As the lung expands, the peripheral, parietal, and visceral pleura rub against each other, and you get these little dots as the lobular tissues move. What happens when it goes wrong, though? So here we are, my colleague Matt decides that there's a real problem.
Nothing at all, there's no sliding whatsoever.
No sliding whatsoever, he's saying to me, okay? What's going on? He's looked on the right-hand side here, something's happening. So here's his view again. If you look at that white line that's moving, rather than just sliding backwards and forwards, left and right, it's kind of pulsing, isn't it? This is called lung pulse. This is a sign of atelectasis, absent distal expansion. Interoperatively, there are a few reasons for that. It could be a sputum plug, which seems clinically likely if you've got a patient with a chest infection. But actually, if this was on the side of non-ventilation, you may end up with an endotracheal intubation. I, for one, do that sometimes if I'm intubating under duress. And I can find that actually I need to pull my tube back. There are ways of finding out where your tube insertion depth should be, an ultrasound as well, and they're increasing validatory work for that too. But it becomes really obvious. But if I'm not totally sure, I can drop this yellow line at the top there, which we call M mode, to slice across. And along the bottom there is a moving line that's got horizontal lines with little vertical bars across it, and we call those T lines. That, to me, says that that lung is not ventilating for whatever the reason is. I may have listened and I can hear transmitted breath sounds from the other side, but I definitively know that there is a problem. Quick and easy and all there for you. In the UK, Regional Anaesthesia UK, who are affiliated with the European Society of Regional Anaesthesia, have put out this thing called their Plan A blocks. They say that all anaesthetists should be able to undertake 7 regional anaesthesia blocks. They've picked the most efficacious and probably the most easy to deliver blocks. They think everybody should be able to do them. And I agree with them because actually they're really useful. And somebody should be able to pick up something probably in their region of anaesthesia, whatever they undertake. But I put this to you as well and show you that actually with these new high-frequency probes, with the new machines that have got increased post-processing as well, it's really very easy to see stuff. This is the posterior border of my own sternocleidomastoid muscle, and sitting up atop it, we'll be able to see my posterior auricular nerve. If I scan up and down, it goes left and right. So if I then put that forwards and I scan that, why do I want to see it? See if you can track it with your eyes. Okay, because when it sits down by the posterior border of sternocleidomastoid, that's exactly where the superficial cervical plexus sits. If I put 1 ml of local anaesthetic there, I can have anaesthesia to the whole of the anterior border of the neck. That's really useful for when I have on my emergency list people having vascular lines inserted, be they for hemodiafiltration or for central venous access for parenteral nutrition or for vasopressors. It's really useful. If I play that again, what I've done here is I've actually post-processed it myself, and I've put a little marker on there for you to be able to see it in red. That's me doing it in my Adobe software at home. But with the new generation of equipment available, for example, with companies like Intelligent Ultrasound, you can actually have this in real time, and you can teach people to be able to have a look at. And of course, that marries up beautifully for regional anaesthesia. And as a result of these increases in high frequency, it may well be that the last time you looked, there's an increased number of regional anesthetic blocks that you could use. There are RIS blocks and PENG blocks and IPAT blocks, and it's all thanks to this increased resolution. So have another look and see if there's some new blocks that are made available to you with increased quality of regional anesthesia. I have to say, for the interest of balance, that when I looked at the evidence behind my beloved superficial cervical plexus block with regional anesthesia, it's not faster and apparently it doesn't give any increased patient benefit or satisfaction. But in my practice, I teach all my residents and my trainees to be able to do it because it actually means that they can be very sparing with a local anesthetic and not distort the anatomy for insertion. What about the future? We're here to talk about the future. Well, the future, AI, of course, everybody's talking about it. But the machines are also getting much smaller. I said that there are lots of these around, but they're certainly shrinking. And as an intensivist, I go and do outreach, and I go out and about, and I have one of these. I literally have this in my pocket, and I'm able to see things. And what are we starting to see? We're seeing stuff that's developed on the larger machines coming to the smaller ones that are really useful. So back to AI. Well, it's not quite AI. I don't have ChatGPT attached to my anesthetic ultrasound machine, but I certainly have some machine learning, and I've got a couple of things that are really useful. If we have a curvilinear probe, low frequency 1 to 5 megahertz, they're actually fantastic for looking at the whole of the lungs. So rather than just looking at the top, I can do a whole sweep of all of the lungs and I can stitch it together. So the machine learning then, rather than giving me these 8 points as separate, static images, not quite sure what's going on, I can put them all together and I can get a proper dynamic look of the whole of the ventilation of the lung, and I can then spot, or at least if somebody else takes a lung sweep and sends the imagery to me, uploads it to my PAC system or even remotely sends it to me, I can work out where the problem is in the lungs and I can say what's going on. That may be useful to me as an anaesthetist intensivist, but I'm finding increasingly useful for directing physiotherapists who are doing chest physio for my patients as well. And certainly this is beautiful for detecting not only pneumothoraces, but also how big the pneumothoraces are, and deciding whether or not, depending on the underlying etiology, whether or not I need to put a chest drain in or I can conservatively manage it. Really handy. If you end up interfacing with cardiology sometimes and you've got a patient who has reduced cardiac function, what do they want to know? Well, they want to know those magic words. What's the ejection fraction? Tell me about the EF. Sometimes you'll know that preoperatively because they've had preoperative echocardiography. That's fine. But then when it all goes wrong intraoperatively, how on earth do I know? It's a nice objective measure for comparisons. If you don't know how to do it and it's not basic ultrasonography or echocardiography, why not let the machine do it? Then we add the third probe to our family, which is in the middle there, which is a cardiac phase array probe. A lot of the machines out and about, as you can see now, have got 3 probes on them because then you've got the full gamut of probe technology to be able to use. If you're able to get one of these, which is an apical 4-chamber view, on the right-hand side of the screen there is the left ventricle and the left atrium, the machine will then tell you what the ejection fraction is, 60%, nice and normal, okay? But it also tells you how it's doing it. So if you've got any skepticism from your cardiological friends, they can have a look at it and say, okay, I get that. That's a fractional area change. I believe the computer. And then you can quantify that in relationship to how it was before with the patient. So I think with the future, you'll be able to branch out and you'll be able to develop. I think if you haven't had a good look at what's available with ultrasound, you should be able to grow, definitely. Increase your capabilities. There's new technologies and new clarities available. And whatever's going on, the future definitely is bright, but it still has a future that's very much black and white. Thank you very much.
Thank you, Justin. Thank you very much. It's really amazing to see how many new applications of ultrasound have been implemented in the last 10 years, because it's really an explosion of new tools that you may use for ultrasound. It's really wonderful. So what we can say, it may the power of the ultrasound probe be with you all. I mean, it's really a technique that needs to be deployed in full. So, Justin, will you please introduce the next speaker?
Absolutely. Thank you, Marco. So our next speaker today is Yann Gricourt. He's an MD, anesthesiologist. He's currently working in the Department of Anesthesia and Intensive Care of the Calmar University Hospital in Nîmes, in France. He studied at Montpellier Nîmes School of Medicine and trained also at the University of California, Los Angeles. He holds a master's degree in health services and clinical research from the University of Lyon. He's completing a PhD degree about regional anesthesia and opioid-free anesthesia, and his clinical research interests include quality improvement, clinical decision-making, patient experience, and regional anesthesia. And Dr. Gricourt today is going to speak to us about how Care Station Insights can help elevate perioperative care. So Yann, over to you.
Thank you so much. Hello everyone. Thank you for your presence today. It's almost time for a coffee break, but I'm gonna spend a little minute with you talking about how Care Station Insight can help the perioperative care. I have only one conflict of interest. But before talking about technology, I would like to introduce this concept about one of the experience I had was I was in fellowship at UCLA and talking about what we know in guidelines, but what we don't necessarily apply in the operating room. As you know, the opioid crisis was a big difficulties for USA and a big challenge for anesthesiologists in the United States. And when I was on fellow at UCLA, we did a study to assess the prescription of opioid at hospital discharge. And interestingly, we found that in opioid-free anesthesia for colorectal surgery, contrary to what we might expect, almost all patients were discharged with opioid prescription at the end of their hospital stay. It was a huge message for the team, and immediately they changed behavior of practitioner. So what does it mean? Because following this example, the question is, how can you measure and how can you change your practices in your anesthesia department? Because conducting a general anesthesia is a very big challenge for you guys every day. And the technology might help you every day to assist different practitioners, anesthesiologists or just nurse anesthetic, to delivering a quality anesthesia. And today, by using two different examples from just the daily practice and daily complication, we're going to talk about how the Care Station solution may improve the perioperative outcome and at the same time, how it can help healthcare practitioners to change in their behavior in the operating room. So, recent low protective ventilation guidelines have been published for surgical patients, and these guidelines are generally known for practitioners, but not always applied. The LPV triad is just 3 different points that I guess you already know, guys. A low tidal volume, a PEEP, and different recruitment maneuver. So it's easy that the goal of this triad is to improve perioperative outcomes such as reduce the postoperative pulmonary complication and at the same time improve the intraoperative pulmonary function. But in your anesthesia department, how can you be sure that these guidelines are already applied in your daily practice? And to respond at this question, you need just objective data. So if you look at regarding manual data collection, you have several limitations, such as being time consuming, that's the real life, and at the same time you can have mistakes regarding the human data collection. So what is the solution to get automatically collection of this data and finally to improve the quality of the collection of this data? So the Care Station Insight solution is a software developed by General Electric that provides data collection, and the way it's very easy to understand that it captures and analyzes over 300 data points from the anesthesia machine, from the monitoring devices, with parameters such as gas value, ventilation setting, blood pressure, many outcomes that are recommended to monitor for general anesthesia. So a couple of years ago, it was before COVID-19 crisis. In collaboration with General Electric, in my team at hospital, we conduct a study using the CureStation data solution, to assess the team behavior regarding the lung protective ventilation. So let's take a few moments on this slide about the study protocol. Our study was a before-after study, and it consists of 5 different sequential phases, starting with a baseline analysis of our practices. And then we have different steps, different period, where we assess clinical outcomes with educational session about LPV, with staff, lecture with the team, or just a meeting with nurses anesthetic. And at the first steps, we add pop-up message on the screen on computer when practitioner conducting the general anesthesia. So the primary outcomes of this monocentric study was the staff adherence to the 3 points of the LPV. So at the beginning, so at the baseline, the LPV adherence was only 7% in our team. And we can see over the time with different steps, pop-up and educational program, we can see the personnel kept increasing over the time with a peak at 28% when we add digital pop-up. And with the over time, it decreased at 22%. But the main message of this study is finally with data collection and different way of education, the staff adherence to the LPV point, which is a good thing for our patient, was increasing over the time. Now, with the second example, let's talk about the challenge of the intraoperative hypotension. You know all that there is no widely accepted definition of the hypotension, and it's keep being a huge challenge for the daily practice. You already know that with these guidelines that you can have an organ injury when you have a low MAP exposure during surgery, and especially when you're increasing the duration of this hypotension. But more than the low MAP, you have the triple low concept that is a strong predictor of a postoperative mortality. So if you take a moment, just as a question, you have every day in your practice many parameters. And if you take a look at the intraoperative analysis of all of these parameters, it's very important. Why? But first thing is to improve. If you look at this, you improve your real-time anesthesia drug delivery. It's what you already do, I guess. But if you look at these parameters, you can track the protocol compliance of the parameters every day in your operation. So let's introduce the IOA adequacy of anesthesia concept made by General Electric. It's made up of different parameters which helps the clinician to assess in the real time different patient individual response to the drug delivery with hypnotic, opioids, and NMDA drugs. In other words, the IOA gives a kind of feedback to the clinician to help to optimize at the end the anesthetic drug administration. So about the IOA administration, parameters provide, it's a continuous non-invasive measurement of 3 points. The first one is the state of the brain with the SE entropy, the patient response to the surgical stimulation with the SPI, and the state of the muscle relaxation with the NMT. So let's take a moment together to see how it looks on your screen operating room. So this is a screenshot of our dashboard, the configuration. This is the first step you have to put with your team. So before compiling and analyzing all of the data you are producing in your department, you have to have some rates and some target with your team, some target range for each parameter, or just take a look and about unwanted events such as low map or bradycardia. So first step is to put in the computer a kind of range that you want to work with it for the rest of the anesthesia. As you are save these parameters, you can start to track your team progression over the time because you have a huge feedback of what's going on, or just adapt in the real time what's going on in your operating room or in your anesthesia department. So this is another screenshot of what you can see with your team, because the AWA monitoring is displayed on 2 pages. The first one is the AWA statue, and the second one is the AWA analysis. This is the AWA statue, the first step, and it offers a kind of real-time view of what's going on in your operating room. I can compare it with the ground control room in the airport, because you can see the number of operating room and different anesthesia statues, the emergence, maintenance, or induction of your anesthesia. So it's a kind of big control of what's going on in your operating room. And the second step, you put different target for your team and for your machine. So you have the AWA analysis that give you in all of the different connecting operating room data to follow what's going on. Let me focus. You can. There is many information in this slide, but just focus on a few of them. You can see the protocol compliance over the time, and you can see the benefit of, for example, an educational program of your team, and you see that after education and pop-up and things like this, you have a better protocol compliance of target ranges. If you focus on unwanted events such as intraoperative hypotension, you can follow when people are in the range or not with this green point or red point. So the advantage of this dashboard is to give you a huge view of what's going on in the past and to follow different protocol compliance when you want to just to try to improve your team management. And an interesting thing, because sometimes you can have the question, these activities are completely anonymous. I mean that you don't have information about the patient name, you don't have the information about the practitioner name, so it's completely anonymous. You can see what's going on in this room, but it's not a kind of tracking behind you to see if you are doing a good job or not. It's something very objective with objective data, completely anonymous, to have a big feedback to understand what's going on in your room. What's my take-home message? Just in a few words, it's a new technology, and that can help you for monitoring implementation of different guidelines, such I saw you in this presentation, or just to monitor an educational program that you want to implement in your anesthesia. But don't forget that we are using more and more than we talk today, more and more technology in our department, wards and operating room, or just in ICU. And for care station inside solution, it's just for you a kind of partnership that can help you to elevate and have better outcomes. But don't forget that it's a kind of second brain for you, but at the end you keep having in your hand the control of your anesthesia ranges and your anesthesia solution to improve the patient outcomes. Thank you.
Yann, thank you very much indeed. Come and join me and Frederic as well. Come up on the stage, and we've got some questions. It's nice to know that things can be done to improve the quality of anaesthesia for our patients and have some objective feedback according to metrics. That's fascinating. Frederic, a question for the audience from you, which is that the survey of anaesthesiologists you reviewed indicated nursing resistance to continuous monitoring was a concern. What are the keys to drive successful implementation technology acceptance?
I think there are multiple keys. I mean, the first one is to clearly explain that these monitoring systems are very different from the existing systems we are using today in the OR and the ICU. And then, of course, I think it's when they try the systems that they will start to understand the potential value. They will start to understand that it will enable the early detection of clinical deterioration, and at the end, it will even actually decrease their workload. So I think it's a process, and we have to go step by step. It's like for any implementation of any new strategy. I mean, it takes probably a bit of time, but once they understand the potential value, and also once they get the feedback from patients, because I think patients also have very often or report the feeling of safety. They know an electronic device is watching them basically continuously, so they get this feedback from patients, and they quickly and easily understand the potential value. But the very first step is clearly to explain these systems are completely different from the classical pulse oximeter you would bring from the OR and then start using on the wards.
Fantastic, thank you. Yann, I've got a question for you as well. What's the most effective education and communication strategy to share care station insights data with your team? Do you share the data outside of the Department of Anesthesiology?
So the question is about what we are sharing with the staff. To be honest, some of the anesthesiologists are very interesting on what's going on and about their own data, and some of them who were less interesting about kind of big data don't really want to know what's going on with their data. But it's very variable in the team, but most of them are interesting to see what's going on, because in France, for example, we have many nurse anesthetic in the operating room, and to be honest, anesthesiologists are in operating room in the induction, and we are staying sometime. It depends on the kind of surgery, but the maintenance of general anesthesia is done by nurse anesthetic. So you have a couple of room to check, and this solution can help you to have a big overview of what's going on. And with this kind of data, you can teach for nurse anesthetic or just residents that the impact of small variation of your anesthesia.
Thank you. I mean, I think that would be fantastic. I'd love to see that sort of thing in my department. I think although Big Brother might be watching me, I think it would be nice to know how I'm doing. I've got a question that's been asked me, and if you've got any more questions, don't forget the microphones either side, and if you want to ask anonymously, please do use Slido. So a question I've got, which is, I demonstrated the use of ultrasound to evaluate cardiac function. What's the comparative level of training required for the 4-chamber view versus more frequent use cases such as line placement? So in the UK, there are a variety of training schemes to get people up to a point-of-care ultrasound focused question for cardiac ultrasound. And the average number of cases that you need to be able to do is 50. And I teach a lot of people. I teach anesthesiologists, I teach acute physicians, emergency department physicians, and things like that. And people who've had exposure to ultrasound previously, such as line placement, I find that they have those sort of eye-hand coordinatory skills much better, and they're able to take to it. And in terms of trying to get people up to speed, certainly within the UK, for example, the Association of Anaesthetists are running courses now called the Periop POCUS, saying, okay, so you're an anaesthetist, you want to know more about intraoperative management, here's something you can do with ultrasound. They're following the same guidelines with 50 cases, and we're going out and teaching people how you can do it intraoperatively. And when I have people who are doing those sorts of things with me, I do an unselected trauma list, and I will, whilst we're waiting for the surgeon and stuff like that, will very often put a cardiac probe on a patient and have a look. And it's amazing what you find. The little old lady who's got the fractured neck of femur, who's got the little systolic murmur that the baby doctor has picked up, turns out sometimes to be something a little bit more sinister, and actually turns out possibly for the reason that they've fallen over and broken the hip in the first place. So about 50 cases or so. And we're just asking binary questions. Is there something worrying? Should I be phoning a friend about it? Got another question, which we got as well, and we had pre-submitted as well, which was for you, Frederic. Can we rely on Bluetooth connectivity for mobile monitoring on the wards? Everybody on the ward is on their phone the whole time. Is that going to interfere, or are there more clinically safe hospital systems that we can use?
Yeah, as I tried to explain in my presentation, I mean, the problem of Bluetooth connectivity is disruptions. I mean, we all experience disruptions when we are using earpods, or it's not a big deal when you are listening music, right? But if you really rely on these monitoring systems to detect clinical deterioration as soon as it may happen, we clearly need to trust the connectivity protocols. That's why I think, and the good news that there are now medical-grade connectivity protocols which have been specifically developed to ensure we get vital sign information 100% of the time. So I think it's available, so we should prioritize, of course, these kind of tools.
Okay, thank you. And Yann, got a question for you. What part of the LPV dashboard was most useful for defining the objectives and analysing the evolution of protective ventilation guidelines? What part of the dashboard was most useful in defining the objectives and analysing the evolution of practice for ventilation practices? Which was the key bit? Yeah.
For which part? Interesting question, because for this part, maybe you're talking about the study I show in these slides. It was not the big deal was recruitment manner. Okay, it was very hard to put it for the team. Even we had some pop-up, and when we take a look today at different data, we are pretty good for a low tidal volume. We can see on the dashboard, we are pretty good for the PIP, but for the recruitment manner, it keeps being hard. And we can see on data since this study that the rate is not always very high, less than expected with our team.
Great, thank you. And I've got one question, probably the last one for us, which is me.
Then I have one for you.
Well, you got one for me. Oh, okay. Well, you ask your one, then that's fine. Go for it.
Yeah, you showed these very interesting new ideas of about the use of the ultrasound probe. One of the usual concern around doctors with the use of ultrasound is about the learning curve, so the operator dependency. What can you say about that? How is it? Is it easy to learn those new methods? Is it difficult? How long does it take to learn?
So in ultrasonographic training for point-of-care diagnostics, we often say that people have their epiphany at scan number 10. And what happens is that they get that eye-hand coordination, they look at stuff, and then suddenly around the 10th scan, they get this magic light bulb moment and they go, aha, what I'm seeing on my ultrasound screen, putting that with what I understand about my clinical patient, I really get it. That drives them forwards. And about 6-7 years ago, we did a survey of practice in the UK for looking at point-of-care echocardiography, so for heart scanning, and we found that those people that managed to get past 10 scans would then rapidly go on to do the 50 for accreditation. So it really does strike home that once you've got 10 scans under your belt, you get your hand in and then you get to see a married up with a clinical scenario, you suddenly think, this means something to me, and then they push on. I think that's about all we've got time for, actually. So it just remains for me to say thank you very much to Frederic and Yann, speakers. Thank you for Marco for hosting us as well. And thank you, have a good rest of the conference.